We are live.
Okay, Sunil, thank you. Good evening, everyone. I, on behalf of the entire CFS family, welcome you to this unique program, 1C before Center for Sight makes it coffee at Center for Sight. And we have been running this program successfully for last so many years. In fact, 2014 we had started, and then in between COVID era came and we had to do it virtual. This year we started in September, and thanks to Ritika again for pressurizing that we have to continue this academic exercise. And because of her, we started this, and Tulika has been the sheet anchor of all these episodes. So we sat down and decided that this year, from September onwards till next year March, we will be doing around 7 episodes of Coffee at Center for Sights. And all these episodes, as all of you know, are the basic aim is that all of us are connected, and all these zones, north, south, east, west, central, where Center for Sight has presence, we thought, you see, there are so many good clinicians and good, surgeons. So they have so many volumes of work. So some odd case we'll keep discussing and sharing knowledge, besides getting to see each other and knowing what work is being done where. Apart from that, all these episodes deliberately, I think Ritika said that we will make them competitive so as to infuse an element of competition. And the best of the best gets the Chairman's Trophy, which is a running trophy. Last year it was won by Telangana, and I hope this time we will have a new winner. And my basic aim is to make it so competitive that everybody brings in their best, have best photographs and best case presentations and best videos presentation here done. And so like this year we started Telangana, and this was the speakers here led by Santosh Flower, and this was the team of Telangana Andhra Pradesh team. And we also have this quiz just to make it more lively, apart from sometime music or other programs. So quiz also, you see, I believe quiz is not only a competitive and prize money, but is a teaching kind of quiz. So the winner in Telangana was Dr. Christie, and she won a huge 10,000 bucks, which has already been couriered. And runners up in this same was Dr. Rajaram Reddy. He also has been couriered 5,000 bucks. This all is courtesy CIPLA. And then we moved to Delhi NCR. And this was the team, and this was the program, and this was the entire team. And the program was coordinated this time by Dr. Harsh Kumar and Dr. Avneen Gupta. And we had some lovely presentations here and quiz done by Dr. Akansha. And the winner of the quiz was Dr. Divya Agarwal. 10,000 bucks, again, reached well in time within a few days of finishing of the episode. And the runner-up was Dr. Kanika. So congratulations to all of you. I wish that this competitive spirit in CFS continues. And this is in nutshell today's program. I will not go into detail, but nutshell, we'll have 2 case presentations. Double trouble by Dr. Sabita, then we'll discuss it. And then two patients of CSD. After that, we'll have a lighter moment, musical moment, and we have a ophthalmic anesthetist with us who will have some lighter moments with us. And then we'll have clinical talk by Dr. Devasis, and then quiz by Dr. Sen Gupta. So the program coordinators for today are Dr. Devasis and Dr. Sen Gupta. Case presentation first will be done by Dr. Sabita, which will be discussed by Dr. Pranab Das. And this case is a case of collarbone with macular hole. Second case will be 2 cases of CSD presentation. CSD is not a very commonly encountered disease. We learn it historically only, but we'll learn more about it today and discussed by Kesav Haldar and Dr. Rashmi. And then, as I said, the musical moments will be coordinated by Devashish and Sengupta. And then we'll have IOL platter as clinical talk by Dr. Devashish. And few comments. See, normally in a clinical talk, we do not invite too much of discussion, except a couple of comments by Dr. Basu and Dr. Vinu. And then quiz will be coordinated by Dr. Sengupta. So before we hand it over, as is usual, I'm very fond of having some, motivational this thing. So Devashish, for 2 minutes, just bear with me. This is a small video presentation of around 1.5 minutes, which gives you tips for success in your daily life. Daily life, all of us are burdened with so much clinical work, so much of, arguments here, fights, small fights everywhere. So what should be done so that ultimately all of us, you see what I am looking here for everybody at CFS, all of us are happy and successful. So just listen to it for a minute.
I started succeeding when I started.
Is it audible?
Yes, sir.
Yes, sir.
आवाज आ रही है?
जी सर आ रही है.
अभी नहीं आ रही सर, प्ले करना पड़ेगा.
हाँ, एक सेकंड अभी कर देता हूँ.
I started succeeding when I started leaving small fights for small fighters. I stopped fighting with those who gossiped about me. I stopped fighting with my in-laws. I stopped fighting for attention. I stopped fighting to meet public expectations of me. I stopped fighting for my rights with stupid people. I left such fights to those who have nothing else to fight for. And I started fighting for my vision, my dreams, my ideas, and my destiny. The day I gave up on small fights is the day I started becoming successful. Ladies and gentlemen, some fights are not worth your time. My humble request to you is, please stop fighting. Be it with your husband, with your children, with your in-laws, or with your servants at home. Please never fight. How big your house is, no matter how huge your bank balance is, no matter how recent your car is, no matter how powerful your position in life is, at the end, the size of our graves will all be the same. So please remember that the most important lesson for all of us to learn if you want to become successful, be it in your family, be it in your career, be it in any walk of life, shed your egos. Ego is killing mankind. If all of us can shed our egos, I'm sure there'll be peace on earth and there'll be progress and prosperity. I started succeeding when I started leaving.
All of you are wise people, but I thought just as a reminder, tips for success are like the gentleman already said, stop paying attention to the small fights with anybody. Instead, fight with your own vision and ideas. Develop your dreams. You see, our chairman, Maipal, keeps telling about develop your dreams, give importance to that. And because these small cribbings, I say 2 C's are not important. Don't crib and don't compare yourself. You have your own vision, your own ideas. Develop wherever you are working, whether in Bihar Center or Southern Enclave, wherever. Develop your vision and give shape to it. So that ultimately, once our center succeeds, everybody succeeds. And most important, lastly, he said was shed your egos. So with this small inspirational thing, I hand it over to Dr. Devashish for carrying the proceedings of this episode number 3. Over to you, Devashish.
Yeah, thank you, sir. Good evening, everybody. Welcome to this episode of Coffee with CFS. And this is from the East today. So let's start with our program. And the coordinator for today's program will be myself and Dr. Shubhrangshu. So over to you, Dr. Shubhrangshu. Let's start the program directly. Shubhranshu, please unmute yourself.
Thank you so much, sir. So we are already in the midst of opinion leaders of today's ophthalmology world. So we thought, let us talk about the legends who shaped ophthalmology as we know it today. So we'll be talking about a few famous eminent ophthalmologists. We'll take it as a trivia. We know that the quiz is at the end, but let's see. So here we are talking about a professor in ophthalmology from Leuven, Switzerland. Between 1919 and 1934, he published 40 papers on pathogenesis and surgical treatment of retinal detachment. He postulated that hole was the cause rather than the consequence of retinal detachment. He pioneered the procedure of ignipuncture, the first successful surgery for the treatment of retinal detachments. The Nobel Prize Committee considered awarding him the prize, and a questionnaire was sent to several ophthalmic authorities worldwide. All of them sent favorable replies except Alfred Vogt. He was actually one of the three who described the weak age disease. So the committee said, let's hold it for next year. And unfortunately, we lost this legend in between. We are talking about none other than Jules Gonin. So with this background, we go to the first case presentation. Double trouble, a case of choroidal coloboma with macular hole. It will be presented by Dr. Babita Kumar. He's a VR consultant from Center for Sight, Patna, did his post-graduation from UCMS and GTB in New Delhi, and did his VR fellowship from Narayana Netralaya in Bangalore. The case will be discussed by Dr. Pranav Das, Senior Consultant of CFS HAC as well as Madhyamgram. And Dr. Das did his post-graduation from PGI Chandigarh. So over to you, Dr. Savitab, with your case.
Thank you, sir. I'll just share my screen. Yeah, good evening, everyone. Good evening, sir, and all my seniors here. I hope my presentation is visible.
Yes.
Yeah, am
Yeah,
I
please
audible?
carry.
No?
Yeah.
Yeah,
Everything is good. Please carry.
I'll present a case very close to me. It was a case of full thickness macular hole with choroidal coloboma. A 17 years old male presented to the OPD with diminution of vision in the right eye since 1 month. The best corrected vision in the right eye was 20 by 200, and whereas the left eye vision was normal, 20 by 20. Left eye, the complete examination was normal. Right eye, when I saw the fundus, generally in the busy OPD, I just saw there was an inferior iris coloboma with lens coloboma. So I saw the fundus, and when I saw the fundus, there was a type 2 RC coloboma with full thickness macular hole, which was not picked up at the first examination. Later on, when I did the fundus photo, I noticed that there was a macular hole just adjacent to the edge of the choroidal coloboma, which is very rare. And then I noticed it, and then I underwent the OCT, which was confirmed on the OCT. So the hole was continuous with the coloboma. So the patient was given the option of macular hole surgery, but the patient was young, and the attendant were not that cooperative, so they refused the surgery. So on literature search, discussing with the patients, I considered the patient first for pneumatic retinopexy with 0.4 cc of 100% C3F8 was injected, and their literature also showed the improvement in the hole. So on the post-day injection, the hole was same, whereas the small bubble went into the sub space adjacent to the macular hole. So on the regular follow-up, there was no significant improvement, and the hole was this was the OCT post pneumatic retinopexy at day 15. So after convincing the patient and they attended multiple times, so I planned the surgery like vitrectomy with ILM peeling with tamponade. and I'll present the short video of the surgical video. The 25 gauge vitrectomy was done. We can see a huge RC coloboma. Then the vitreous was stained with the tricod. Very careful vitrectomy was done in order to prevent any iatrogenic break. The macular hole was stained with the blue for 2 minutes. The ILM was peeled, but the peeling was not continuous because there was a counteraction was not present because of the coloboma continuous with the macular hole. So piecemeal removal of ILM was done, and very carefully the ILM was peeled across the macular hole. Due to the continuous of the hole, there was not counter traction was not there, so it was very difficult to peel the ILM in one go. So possible leverage laser was done around the coloboma. So after the in the follow up during surgery, am I audible? Hello.
Yeah. So
Yes, you
we
are.
can hear you. We can hear you.
During surgery the separation of the posterior cortical vitreous was very challenging, and I made sure that there was no occurrence of any retinal break at the margin of the coloboma. So there was a visualization during the surgery, so that as the air could enter the antechamber and the filling of the tamponade. This is a frequent follow up of the OCT of the patient. We can see that there was a pre-op OCT. Day 1, day 14, and day 28, we can see the complete closure of the macular hole with no continuous with the coloboma, and the surgical result was excellent. So this was the presentation of the macular hole at the presentation. This was 2 weeks post surgery, and this was this is 4 weeks post surgery. You can clearly see that the hole was totally closed. Type 1 closure was achieved. At final follow up, 4 months, it was a silicon oil field eye. Retina was well achieved, and we achieved vision of 20/60. So after the complete 3 months removal post silicon oil, the vision we achieved was 20/60. So to summarize, macular hole at the edge of the choroidal coloboma is a very rare occurrence. Very few cases has been reported in the world. The surgical technique is not still well established. We received a very good result showing both anatomical closure and significant visual improvement of the patient, and the patient is highly satisfied. Thank you so much.
We now invite
Babita, it's a fantastic surgery. I don't know why you said it's a fantastic ILM, peel you initiated.
Yeah.
And although rare, this combination,
yes.
But I think nothing better on the earth would have been possible by anybody else also.
Yes.
The only thing my concern was before, we discuss it out was why in the first instance, you see, we never consider pneumo at all in today's era of MIPS. So I was just wondering, why did you consider pneumo at all?
The patient was not at all ready. So I thought of doing something and convincing him for multiple times. He was not ready for the surgery. So I thought, let's give it a try. So I was sure that it will not close, but then also in order to keep the patient not too lost to follow up and not to lose the patient.
You see why the reason I'm saying so, because it was an unusual patient. There are coexisting. If a young patient एक macular hole है, coloboma है. Pneumoretinopexy, Hilton propagated, or believe me, it has generally died. It has not, lived up to that expectation. We do use very rarely now, very, very rarely. You see, it's not such a frequent occurrence. I used to do pneumo when I was in RP center, even at Center for Sight, did a couple of cases.
Yes.
But it's not a preferred kind of, especially in practice, if you are there, because if you do pneumo and it does not succeed, it brings a bad name, and then for second surgery, it's very difficult to convince a patient. भाई ये नहीं हुआ, आप ये करवा लो. So especially I'm concerned about practice scenario. In institutional maybe you try, but in practice scenario generally we have to give if best kind of shot in the first instance itself.
Yes.
So let's hear the discussion part, then we'll come back.
As said by Dr. Burma, it was very nicely managed case. I was
very
difficult, but very nicely managed. I was just wondering whether laser could have lead to the failure, because it will lead to the contraction at the near the hole.
Pranab, can we see you, or you will speak like this only?
No, sir.
And do you have any do you have any slides, or you will?
No, I don't have any slides, sir. I don't have any slides.
So wonderful. Sir. You see,
So,
like I said, it's a wonderful piece of surgery done. Excellent.
Yes,
Excellent surgery done.
Sir, I just want to know, like Lalit sir, like how many cases in your in so many of years of experience, sir, like coloboma with macular hole is like.
I saw one patient in RP center. That's nearly 20 years back. Yes. In this practice and center for sight, I haven't seen or done any patient here. But at RP center, I did operate one of such patient. At that time, we never used to have BBG dye, yes. and we used to do that ICG kind of stain, and we never used to stain with BBG. BBG came much later, and unfortunately that patient had a detachment also. You see, that patient was not a flat retina. I remember that child, 11-year-old. That patient had detachment also associated, and this hole was discovered on the table itself. We did not diagnosed pre-operatively.
Same happened with me, sir. In the OPD, I missed the hole. Later on I realized, oh God, I missed the macular hole at the edge of the coloboma.
So let's hear Pranab comment. Pranab Das.
Yes, sir. I was asking doing laser at the coloboma edge, if there is no RD, whether it would have hampered the outcome. I mean,
it's a controversial subject, honestly speaking. You see, the big study in Shankar Nethralaya, these people are not fond of doing prophylactic laser. But if you read a lot of these books, you see there's a 40% chance of in the lifetime of this patient of developing, especially if the other eye has had it. But honestly speaking, I personally try to laser all these patients because it does not, honestly speaking, harm any this thing, provided you are very careful of avoiding these sensitive structures. But I heard a talk at Shankar Nethralaya where they are not favorable to do laser unless patient has had a detachment in the fellow eye with the same coloboma. This was unilateral coloboma. Savita,
yes, sir.
Yes.
Yeah. So that's a controversial subject, but I don't think so. Laser-induced fibrosis or contracture will, in any case, harm, because he has taken care of the vitreous by triamcinolone. He has taken care of ILM. The possibility of that happening, and I don't think so. We induce white kind of burns. It's a grade 2 kind of burn, just to prevent the fluid migration into that area. So very nicely managed, I must say, except that one comment which I made, that is primarily to, because pneumo in such patients will never work.
Yes, thank you,
never
sir.
work.
Thank you so much.
But I think you should send a short report somewhere, because surgery has been fantastic. And OCT has been mind-boggling. Very nice OCT you have shown.
Thank you so much, sir.
So any comments from any other person who is there, or we move on? Ajit, you have any comment? Ajit Babu is busy. Okay. So Ajit, so we can move on to the second case because Ajit Babu seems to be busy.
Usually, Lalit, no, I was talking tomorrow. This this evaluation is there.
Any comment about this case?
Yeah, usually I go for a laser in colobomas as a preventive laser.
Yes.
When there is no involvement of the disc margin or the macular center. If that is not there, and if the coloboma is inferior area only, touching the arcades, I go with 2 to 3 rows of burns. And usually it is said that the amount of detachment that can happen is lifetime calculation. It is not that 1 year or 2 years. It is lifetime. And most of the colobomas we see in childhood, so this thing is 40% risk of development of retinal detachment over the life of the patient.
That's what I said. 40% of the life. That is the reason. That is the reason I also agree with Ajit that we preferably do it because it's a lifetime risk. Or you keep following up this patient because the children will never complain, and then they will have squint, and then they will come. So it is preferable that to take this step.
And pneumoretinopexy and macular hole with RD in coloboma is not at all acceptable, even to engage the patient with your treatments. Let us not do that in CFS, at least our brand value will come down.
Yeah, that was the first comment I made before Pranab took over the discussion. And Sabitab agreed. I don't know still why he went ahead, but it's okay. But he said that he knew he will not succeed. But I agree with Ajit that we should not, because practice margin of error, people do not accept all these failures at all.
I lost all hope to convince patient for surgery, so I
No.
Finally, okay. We agree with whatever you have done, but as a mark of discussion, because because so many pathologies are there, na. Coloboma bhi hai, young patient hai, and formed vitreous hota hai, gel vitreous hota hai. Usme macular hole is partly in the coloboma, partly there. So possibility of success is very, very impossible virtually.
Yes.
Second is even if you fail, you do a standard procedure and then fail, people will accept it. Yes, I would have done the same thing, still it's failed.
Yes.
Rather than something which is not expected to give you result and you are doing, people will say why it was done and where it was done and all kind of things.
Yes.
So we should not give any loose ends for others to comment.
Sure, sir.
But the fact that you succeeded, I must compliment Savita. Excellent job.
Excellent.
Yeah.
Well, let's go ahead. Let's go ahead with the second case.
So thank you, Dr. Savita, Dr. Pranam Das. Now we go on to this French ophthalmologist and neurologist whose hobby was music, and he actually published several works under the pseudonym of Eric. Yes, we are talking about someone who described the dorsal midbrain syndrome consisting of the vertical gaze palsy, convergence retraction nystagmus, and light near dissociation. The smile on Dr. Das's face tells us that we are talking about Henry Perinaud. He also described the Perinaud's dermolipomata and the Perinaud's oculoglandular syndrome, which consists of fever, papillary conjunctivitis, lymphadenopathy, and it's a rare manifestation of cat scratch disease. And now we have our second case presentation, Belle the cat, 2 cases of cat scratch disease. It will be presented by Dr. Pranab Das, Senior Consultant at CFS, HAC and Madhyamgram. The case will be discussed by Dr. Keshav Haldar, who is a Senior Consultant at CFS, HAC Bose Road, and Dr. Rashmi Saraf, who is also a Senior Consultant at Center for Sight, HAC Bose Road. And both Dr. Haldar and Dr. Saraf, they did their residency from RP Center, AIMS, New Delhi. Over to you, Dr. Das.
Good evening, my seniors and my colleagues. Though Subhranshu was talking of the Perinaud syndrome, I will be presenting 2 cases of intraocular, not extraocular Perinaud's disease. So this is my first case. He's a 34 years old male patient. I came with sudden loss of vision in the right eye for 3 days duration. He was a non-hypertensive, non-diabetic. There was no history of any systemic diseases. On examination, his best corrected visual acuity was 636 and 24 in the right eye, 6.6 and 6 in the left eye. Anterior segment examination was unremarkable in both eyes. When we examined the posterior segment, we could see in the right eye there was disc edema, and adjacent to that there was retinal opacification of the papillomacular bundle, and there was serous macular RD, and there was a grayish white coloration of the retina inferior to the disc. and the left eye fundus examination was normal. So it's a case of we called as a neuroretinitis along with retinal artery occlusion with the serous RD. We did OCT, this confirmed the serous macular RD, and there was hyperreflectivity at the papillomacular bundle, and there was boggy swelling of the retina, especially the outer retina. And we did an OCT through the inferior, to the area inferior to the optic disc. We could see there are also hyperreflective to the inner retina as well as boggy swelling of the outer retina with some amount of fluid in the subretinal space. We did fluorescent angiography. We confirmed there is vascular occlusion at the papillomacular bundle, and there was retinitis-like patch at the area inferior to the optic disc, and there was disc leakage from the disc. And the retrospective history taking, when we saw the cases of neuroretinitis along with the retinal artery occlusion, we thought it could be a case of cat scratch disease. So we did take the history. The patient was not forthcoming with the history. So, but ultimately he told that he had a cat scratch at his right hand 6 weeks ago, followed by there was a mild fever which persisted for 3 to 4 days. We did routine investigation like routine blood count, chest X-ray, MANTU, TPHA, ANA, and toxoplasma, IgG, IgM all came negative. So we presume that case as a right eye, presumed buttonal retinitis with branched retinal artery occlusion. And we gave treatment with the doxycycline 100 milligram twice daily for 2 weeks, along with Visolon to start with 1 milligram per kg body weight, then weekly tapered for, and stopped in 6 weeks' time. So this is the follow-up. At 9 days on treatment, his visual acuity improved to 6/24. We could see that there the retinal edema was going down. Optic disc edema was much less. And at 2 weeks follow-up, his visual acuity improved to 6/18 PERD, and the retinal edema was much less, and the optic disc edema almost resolved. At 6 weeks follow-up, you can see the visual acuity improved to 6/18. He has a little bit of hard exudate at the macula. We know that in neuroretinitis, the macular exudates takes almost 6 months to 1 year to resolve. His disc is almost normal now, except for mild temporal pallor, and there was no macular edema. And the OCT also showed the similar findings. We can see that gradual OCT at 2 weeks, the fovea is thinned out. There is no macular edema. Coming to my case number 2, this is a 26-year-old male patient as a graphic designer. He complained of blurring of vision in the upper field of vision in left eye for 4 days duration, probably because of his profession. He could detect this problem early. There is no history of any systemic illness. So on examination, his best corrected visual acuity is 6/6 and 6 in both the eyes. Intraocular pressure was 14, and anterior segment examination was quite unremarkable. And the fundus examination showed right eye was normal. In the left eye, there was a retinitis patch along the inferior temporal arcade, and there was distal to that, there was a subtle retinal opacification, which also hinted at the retinal arterial occlusion. So looking at these retinitis along with the retinal arterial occlusion, again, we thought of cat scratch disease. We did OCT fundus fluorescent angiography, which nicely showed the vascular arterial occlusion of the infratemporal area, and along with hyperfluorescence starting in the early frame, which is becoming more hyperfluorescent in later frames, so suggestive of the retinitis. So we did OCT through the area of retinitis. We can nicely see the very much hyperreflective area of hyperreflectivity at the inner retina, along with the gross retinal thickening. So we did again routine investigation to rule out other causes of retinitis. So all came negative. And retrospective history taking, again, patient was not very forthcoming about the history of cat scratch. After repeated examination, he can actually show me the area of scratch at his left hand between the wave of middle and ring finger. And we could, and then I examined him. He has a axillary limb, palpable axillary limb node in the left side, the same side. So we again diagnosed this case as a left eye presumed buttonal retinitis with branched retinal artery occlusion. We treated this patient with azothioprine, azithromycin 500 milligram once daily for 14 days. This is the follow-up. We can see to start with, there is retinitis along with retinal artery occlusion. And at 2 weeks follow-up, the retinitis was much resolved, much smaller. And 4 weeks follow-up, everything looks very normal. So these are the few case reports where they have reported retinal artery occlusive disease in a young patient with cat scratch disease. We could see here the patches of white retinitis patch along with infratemporal retinal artery occlusion. And this is another case that there is a neuroretinitis along with supratemporal retinal arterial occlusion. Both of the cases are seropositive for the Bartonella henseli. So they manage this patient with doxycycline along with oral steroid. Coming to the discussion, cat scratch disease is a worldwide zoonotic infection caused by the gram-negative rods, Bartonella henseli. The primary reservoir is the domestic cat. Humans can be infected by the cat scratches, bites, or contamination of open surface wounds by the cat saliva or feces of the cat flea. CSD is usually benign self-limiting condition. It normally manifests as a localized papule, macule, or pustule at the inoculation site. And weeks to months later, there may be regional tender lymphadenopathy, general symptoms like fever, anorexia, sore throat, nausea, and vomiting. 5 to 10% of this CSD patient presents with the ocular involvement. Amongst the ocular involvement, as Shubhranshu was telling, it could be adnexal manifestation like peritonial ocular syndrome. This is one of the commonest presentation a patient presents with CSD. And there may be vitreous changes. Most of them has mild vitritis, but it can be moderate vitritis also. At times there may be vitreous hemorrhage. In the retinal choroidal manifestation, there may be near retinitis or chororetinitis. In the retinal vascular manifestation, it could be retinal vasculitis, angiomatous like proliferation, branched retinal artery occlusion, and branched retinal vein occlusion. Whatever I have seen few cases, in most of the patients usually has branched retinal artery occlusion. This is very unusual in other condition, inflammatory condition, where we see more of venous occlusion. Macular complication, serous macular detachment can be there, macular star formation along with the optic disc involvement, there may be macular edema, there may be macular hole. And optic nerve involvement, one of the commonest manifestations is the neuroretinitis, like optic disc edema, optic nerve head mass, angiomatous mass on the optic disc. So when we see CSD neuroretinitis, we have to, it gives some clues will be there to consider it as a neuroretinitis. So those are optic disc telangiectasia, peripapillary axillary retinal detachment, superficial retinal infiltrates, and occlusion of small retinal arteries. Coming to the pathogenesis, the exact pathogenesis of the CSD-associated neuroretinitis remains to be elucidated. The optic nerve involvement might be caused by the optic nerve or intraocular infection by the Bartonella or an immune response to bacterial infection or a combination of infectious and para-infectious mechanism. And why the vascular occlusion is common in Bartonella infection? Bartonella has propensity to colonize and cause a direct damage to the vessel wall, leading to vascular thrombosis and occlusion. Inflammatory process from an adjacent or even distant area of inflammation may further incite edema and thickening of the vessel wall, expanding to the occlusion of the vessels. And vasculitis alone can cause the vascular obstruction. So the diagnosis of CSD-associated neuroretinitis is based on clinical findings, including young age, history of the contact with the cat, typical neuroretinitis, vascular occlusion, especially of the retinal branch retinal artery occlusion, and obviously positive serology. The culture of Bartonella henseli from the blood is difficult and rarely successful. Serological tests are the commonly performed test, though it is very difficult to get in our country. I advised this test to my second patient. By the time he actually inquired about where it is possible, the lesion improved healing. Showed signs of healing, so he could not do the test. So the indirect immunofluorescent antibody test is the most reliable method with high specificity of 95%. There are reports of polymerase chain reaction positive from the lymph node biopsy, so one can consider this also if there is a lymph node, palpable lymph node present. When there is no consensus on the treatment of CSD, mild to moderate, this is a self-limiting condition most of the time. Mild to moderate CSD may not need to be treated. Severe ocular and systemic complication of CSD and immunocompromised patients should be treated. Antibiotic options may include doxycycline, azathioprine, azithromycin, erythromycin, ciprofloxacin, trimethoprim sulfamethoxazole, gentamicin, or rifampin. There is one group which says that doxycycline along with rifampin could be the best option. Immunocompetent individual aged more than 8 years are typically prescribed doxycycline 100 mg twice daily for 2 to 4 weeks. And it has been shown that adding oral steroid to the antibiotics gives better result as far as the visual acuity outcome is concerned in ocular CSD. In conclusion, high index of suspicion is required to diagnose CSD. Neuroretinitis or retinitis associated with retinal arterial occlusion highly suggestive, can be a suggestive feature for CSD. And we need to ask leading question about the history of cat scratch or cat bite while taking the history to have a suspicion for diagnosis of CSD. Thank you very much.
Again, Pranab must say very nicely worked up both the patients. We can stop sharing if you have nothing else. So my only issue, and for discussion before I give it to discussants, is to ask people, whosoever are here, maybe Ajit and maybe other few people, that how many times you see, once you see a patch of retinitis and occlusive, we start thinking of cat scratch disease in clinical scenario. Somehow I keep scratching my head rather than thinking of cat scratch disease. And you have been lucky that in both your patients you could elucidate that history. And what you suppose history was not there. Suppose that second patient had not shown you that patch. So what would you think of? That was my second this thing in the clinical scenario of retinitis patch and occlusive kind of. What you would think of? Suppose that history was not there. You see that history made you wiser, and fortunately this patient responded. And third part was about you said it's self-limiting, but you rightly said that in patients who are visually threatening, like in first patient you had neuroretinitis, and that in those patients you do add steroids in such patients so as to decrease the itis or inflammatory component to it. So let's hear what the discussant have to say about and how we become more wiser before I ask Ajit Babu and other things about how do you think of cat scratch or scratch your head there?
First of all, I would like to congratulate Dr. Pranab Das for such a brilliant presentation, very well documented with all the fluorescent angiograms and the OCT findings and with every follow-up. So the second case was a little bit atypical, like as Dr. Lalit Verma said, it was, but the disc was a little bit hyperemic. And in neuroretinitis, we must remember, like if we think of cat scratch, like macular scar may take some time to develop. So in some patients with papillitis, like it is very difficult to remember, but it is a differential diagnosis of papillitis because the fluid in the macula takes some time to get absorbed. So, but of course, neuroretinitis, whenever we see, the first thing which comes in our mind is cat scratch disease, or what we have been taught, Lyme's disease, syphilis, leptospirosis. Yeah.
Keshav, how many times do you think of cat scratch disease? You are muted. Can you unmute yourself?
Yes. Oh, I think means I have not seen any cat scratch disease as such, but many times this conjunctivitis, viral conjunctivitis patients present with significant lymph node in enlargement, preauricular or submandibular lymph node enlargement.
That is classical what introduction was given, Perinode syndrome or oculoglandular syndrome.
Glandular syndrome. But I think from cat we can have various other diseases as well. Cat scratch disease, this verticellosis is not the only thing which can spread to cat. This thing like tularemia, even rabies, rat bite fever, feline pneumonia, like this diphtheria, tuberculosis, everything can come from cat. And sometimes some diseases are common between cat and human beings, like again tuberculosis, diphtheria, salmonellosis. These type of things can be common. Means other diseases also can come from cat scratch from cat bite or things like that.
So Rashmi and Pranab, since cat is a frequently domesticated animal, especially in US and other, is the disease much more commoner there, or because in India it's more of a dog which is a pet animal.
Cats are very much domesticated. Like we went in England for 6 years, so it's a very commonly domesticated animal. But we did not see like any case of cat scratch, and it is very like Dr. Pranav Das, 2 cases. So in how many, like what period did you see, Dr. Pranav, these 2 cases? Like in how many months duration?
One patient I saw in 2018. This patient, last patient, second case I saw in May 2021. I mean, this year only. He was not at all giving the history. Then I repeatedly asked him, did you have the cascade? Because my suspicion, I saw earlier also this kind of 2 cases where there is a vascular occlusion, arterial occlusion.
But
so
did he have the
that
pets?
gave me the...
They
Yes,
had
ma'am?
the pets at home? They had the pets at home?
Yes, yes. He was carrying actually, the cat has an ulcer at his feet. So he was carrying, he give me the total whole history. So while he was carrying the cat, he have a scratch at his left hand. And I don't know whether there is an association or not. Well, the person's eye got affected is the same side of the crash scratch actually, in both the cases.
So any particular reason you did not do the serology for the first case?
No, I asked him to go for a serology. Then I inquired about also from the Lalpath lab. They said it is possible we have to send the sample to the Bombay. By the time actually we are doing this, he started improving. Within when he saw the improve, I show him this is your picture. You compare this. So he told, why should I go for, sir? It cost almost 12,000 rupees.
Okay.
It's not a very commonly performed test.
Yes.
But hats off to your documentation. Very nicely, very nice, both the patients. Ajit, do you think of cat scratch disease if you see a patch of retinitis and occlusion? Can you unmute yourself?
I rather think of other diseases like the fevers than cat scratch. But keeping cat scratch also in mind is useful. But most of the diseases are self-limiting, except for the cases where it is threatening the macula. So especially in south, at least we will see the chikungunya, dengue fevers. Those are much more common than cat scratch. So
I know Andhra and all, their chikungunya associated with such things as commoner. But cat scratch disease is not so commonly reported for
not
South.
so common, yes.
But in any case, you see, till the time you do that test, diagnosis by and large remains presumed only.
Yes. It is presumed
initial.
Certain times it can be self-resolving also.
Yes. Right. But Pranav, thanks a lot for
the documentation is very good, Pranav.
Very good.
Thank you, sir.
100% agree with Lalit.
Yeah, very good. And what we learned is that we also need to scratch our head once we see of these. The last slide of yours, whenever you have a young patient with features of retinitis and occlusive kind of arterial this thing, and you should think and inquire about history of domestication of cat or history of fever or in lymph node. Such things should be looked into, and then maybe start the treatment what you suggested. But very nice, both the cases. Excellent job.
Thank you, sir.
Devashish?
Yes, sir. So we have the wonderful discussions. Let's take a break, a musical break. After this serious dose of cat scratch disease and this double trouble. So let's invite Dr. Babita Basu. She is on one hand an ophthalmic anesthetist, and on the other hand, she's a very well accomplished harmonica player. Harmonica or mouth organ, as we know, is a very nice instrument. You can play classical music, you can play popular music, and she's one of the doyens in this field. And you can watch her in YouTube, lots of videos, and she has international acclaim as well. So we are very happy to have with us Dr. Babita Basu. We will have a few words from her, and then we'll actually play 2 pieces that she has played. But this is pre-recorded because the proper recording needs a lot of acoustic precision. So we play some pre-recorded pieces. But first, we would like to hear a few words from Madam Dr. Babita Basu.
Good evening. Can you hear me? Am I audible?
Yes.
Yeah. Yes, madam.
Oh,
yes.
Good evening. I am enjoying this session so much. Lot of things I came to know from here, and I think this break, whether it is a good one or bad one, I cannot say because I was enjoying the discussion so much. Perhaps this break is not suitable at this time. I don't know whether you will enjoy my music or not. But I am very much honored that Dr. Debashish and Dr. Shubhranshu, they have invited me to be a part of this session. And this is a wonderful evening for me. And I hope you will like my music. And I am looking forward for your feedback, actually. How did you like my music or you didn't?
Yeah, we will definitely listen to that, and we will. I'm sure everybody will enjoy. So let's hear the harmonica from Dr. Babita Basu.
Wonderful, wonderful.
Okay, I'm sure everybody enjoyed. So yeah. Okay, so we will have another piece. Yeah.
बहुत बढ़िया यार, excellent. Babita, you were saying this is the most welcome break, I must say. Devashish, very nice that. You see, we have another, music-loving person, Dr. Pradeep Sharma, with us. I would ask him to make some comment about that. But believe me, both the choice of the songs were very good, very, very popular, Bollywood beats. And how old is this? These songs. When was it recorded? Because we saw more youthful Babita there.
I did the Made in India one just before the vaccination was started here in India. It was a campaign for people to come out for vaccination. Keeping it that in mind, I came out with that vaccination Made in India thing. And this Rashti Kamar was recorded when the song was popular at that time only. I made it and I recorded it.
But you see, you interspersed with the Covaxin and masks and everything.
Yes,
made it more likable also. Yes, Dr. Pradeep Sharma with us.
I think it's really commendable. It's wonderful. I never imagined that we have so much good talent amongst us. And Center for Sight is really, I think, in a wonderful spot for us. So we also do ophthalmology.
Yes. we also do ophthalmology. better word.
Yeah. Just like
believe me, Babita, in case it was a physical event, I would have seen a lot of people dancing to it.
Yes.
I should have enjoyed it so much, sir.
Next day,
I'm looking forward to present something, live someday. Perhaps it will be possible.
So we will catch hold of Devashish sometimes.
Sure,
but thank you very much for coming. Thank you very much for coming and joining and making lighter moments for us in this discussion we had. I think we need to applause for her. Yeah. Thanks.
Thank you. Thank you, madam. And thank you, Dr. Verma and Dr. Sharma, for your comments. Once again, thank you to Dr. Babita. The music is still on. We will have two more pieces. And they will be played by none other than Shuranjina Banerjee. And she is part of the family of extended CFS, as we can tell, because she is the wife of Dr. Shubhranshu, who is the coordinator today. And a few words before Shuranjina plays the tunes. She is actually multifaceted. She teaches geography in President's University. She's a Commonwealth scholar. She did her master's in sustainable development from Staffordshire University. She's a PhD. She's also a swimmer, water ballerina, and a passionate singer. So let's hear the tunes from Shuranjina, and then we will again dive into ophthalmology.
Thank you, Dr. Chakraborty. Good evening, everybody. And my namaskar to the CFS family. I really feel honored to be a part of this program where renowned ophthalmologists from all over India are present. And I really thank you all for giving me this opportunity. So my first song is from Bollywood, but it's from the golden era of Bollywood. It's from film Kohra, and music direction is by Sri Hemant Kumar. ये जाम भरे भरे जरा पीने दो कल की किसको खबर एक रातों के निडर मुझे जीने दो और तुझसे हंसी तेरा प्यार तू जाने ना ये जाम भरे भरे जरा पीने दो प्यार में है जीवन की खुशी देती है खुशी कई गम भी प्यार में है जीवन की खुशी देती है खुशी कई गम भी मैं मान भी लूं मैं मान भी लूं कभी हार तू माने ना ये नयन डरे डरे ये जाम भरे भरे जरा पीने दो हल्की किसको खबर एक रातों की निडर मुझे जीने दो Thank you.
Great song.
Thank you. The next song is another song from the golden era. Music director is R.D. Burman, Saab.
Majority golden era वाली बैठे हैं.
And it's from film Adi. I'm sure you can all guess what the song is.
Yeah, Mukesh is already smiling.
Yeah, actually really wonderful voice and really very, very refreshing after a hectic day. Thoroughly enjoying the program. Yeah.
Yes, Shuranjina.
तेरे बिना जिंदगी से कोई शिकवा तो नहीं शिकवा नहीं शिकवा नहीं शिकवा नहीं तेरे बिना जिंदगी है लेकिन जिंदगी तो नहीं जिंदगी नहीं जिंदगी नहीं जिंदगी नहीं तेरे जी में आता है तेरे दामन में सर छुपा के हम रोते रहे जी में आता है तेरे दामन में सर छुपा के हम रोते रहे तेरी भी आंखों में आंसुओं की नमी तो नहीं तेरे बिना जिंदगी से कोई शिकवा तो नहीं शिकवा नहीं तेरे बिना जिंदगी भी लेकिन जिंदगी तो नहीं जिंदगी Thank you very much.
You see, choice of the songs, Shuranjina, have been so good that I think all of us are immersed in music today.
Thank you, sir.
Wonderful and wonderful voice you have. Mukesh?
Thank you.
So Mukesh is still immersed.
Truly mesmerizing, actually. Very nicely sung. And as you said, the texture of voice is really very good. So thoroughly enjoyed the program, also scientific program also, and this extracurricular, I should say, initially the harmonica and now the song. Really very good. So as Dr. Pradeep Sharma sir has said that we also do ophthalmology kind of thing. CFS is now maybe developing into that era.
No, we deliberately introduced some lighter moments in this entire program from 1.5 hours, so that just a break from, we had 2 cases, now we have IOL platter lined up, and hopefully by that time our chairman will join, and we'll have good discussion again on that topic. So thanks a lot, Shuranjina, and thanks to Devashish for having a great, voices with us. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir.
So now as we move back to ophthalmology, so now we'll quickly talk about an English ophthalmologist who, while being engaged in wartime services, carried out extensive ophthalmic research on river blindness, snake venom ophthalmia, nutritional amblyopia. Now, this is a picture of a canopy from a British Spitfire fighter plane, and the shrapnel injuries from this particular material sustained by Flight Lieutenant Gordon Mouse Cleaver led to the discovery of something very, very important in ophthalmology. And we have this British ophthalmologist who basically has shown us the anterior segment surgeons the way forward. We are talking about Sir Nicholas Harold Lloyd Ridley. And with that, we move on to the clinical talk, the IOL platter spoiled for choice. The Dr. Devashish Chakrabarti is a senior consultant at CFS AJC Bose Road branch, and he did his fellowship from LV Prasad Eye Institute, Hyderabad. We'll have, after the clinical talk, comments from Dr. Praveen Kumar, consultant from Patna CFS, and he also did his fellowship from LV Prasad Eye Institute in Hyderabad. And we will also have comments from Dr. Dipanshu Basu Chaudhary, who did his residency from RP Center, New Delhi, AIMS. Over to you, Dr. Devashish.
Thank you, Shubhranshu, for the introduction. So let's move on to ophthalmology again. And the topic for discussion is IOL platter spoiled for choice. So change is inevitable, change is exciting. The options are progressive, and nowadays the cataract surgery and the phacoemulsification technology has developed so much that we can almost promise visual excellence to our patients. But over the recent years, we have a lot of newer IOLs coming into the ophthalmology arena, and sometimes we feel a little confused about all these types of physical jargon like bifocal, trifocal, multifocal, extended depth of focus, advanced monofocal, so on and so forth. So we just saw that Dr. Harold Ridley introduced the first intraocular lens, and ever since that time, the physics and the optics of the IOL has developed tremendously in parallel with the development in phacoemulsification technology introduced by Charles Kelman. And now today, we have a plethora of IOLs. We have the monofocals, we have the advanced monofocals, we have the multifocals, we have the new entrants in the market, that is the extended depth of focus lenses or the EDOF lenses, and we have the accommodating lenses, we have the toric lenses, and so on. So before we come to these newer lenses, let us just review few basic characteristics which actually define an intraocular lens and which actually defines how good or bad an IOL is. Like the IOL material, the hydrophobic or the hydrophilic character, the square edge design, the UV blocking property. Some lenses are chromophore, we know. What about the refractive index of the lens? And very importantly, these two topics, chromatic aberration and spherical aberration, and the glistenings. Now, if you come to the material of the lenses, by and large, the hydrophobic acrylic IOLs, they occupy the bulk of the market share. And then we have the other types of lenses like the hydrophilic acrylic, the PMMA, and the silicone lenses. Square edge design, we all know that a 360-degree square edge prevents the posture or reduces the posture capture opacification. There are now modifications in this age also. Now, ultraviolet radiation, all commercially available intraocular lenses actually block the ultraviolet electromagnetic radiations. Now, regarding the chromophore lenses, we know that some of the lenses like the Alcon IQ, that is a slightly yellowish tinted lens, and that has both some theoretical advantages and disadvantages. Like they may theoretically improve night vision because they can reduce light scatter because they can filter the blue part of the electromagnetic spectrum. And we know that blue light actually has the highest scattering among all wavelengths. This is why actually the sky appears blue. And some probable theoretical protection against age-related macular degeneration, but there are some theoretical disadvantages also, like they may somewhat alter the color vision, and they may have some problem with the sleep. They can cause sleep disturbances and can alter the circadian rhythm. Now, refractive index is another physical feature of the intraocular lens that is important, because we know, if you remember the Snell's law, the basic laws of refraction, that is, if the angle of incidence is θ1 and the angle of refraction is θ2, then Snell's formula tells us that n1 sine θ1 is n2 sine θ2, where n1 and n2 are the refractive indices of the two media. And basically what it clinically implies is that the IOLs, which are made of high index materials, they require less convexity, which allows for thinner lenses and smaller incisions. For example, we know that we have the Acrosoft material that is of a higher refractive index, so that is slightly thinner, whereas the Technis material that has a lesser refractive index that is slightly thicker. But higher refractive index has some pitfalls also. We will discover that. Now, what about chromatic aberration? So if you have a lens here and if you have a parallel rays of light, we know that white light consists of several wavelengths or several colors from violet to red. And when this white light is refracted by the lens, then what happens is that because of the variation in the wavelengths, there's a variation in the velocity of these wavelengths through a particular medium. And then each of these colors is actually focused at different regions. So the violet part is focused a little closer towards the lens and the red part is refracted a little away from the lens. So this causes what is known as chromatic aberration. And what this chromatic aberration does is that it can cause a blurry vision or the waxy vision. So in connection with the chromatic aberration, we have something known as the Abbe number, named after the German physicist Ernst Abbe. And what Abbe number means is that it is inversely related to dispersion, and it's generally inversely related to the index of refraction. So higher index materials usually have lower Abbe numbers. The Abbe number in the human lens is about 35 to 60. Lenses which have higher Abbe number cause less light dispersion, therefore less chromatic aberration, and potentially this results in good quality of vision. So if a lens has a higher refractive index, then it will have a lesser Abbe number and it will cause more dispersion of the lens, and therefore it will cause a little bit of visual blur. Now, if we come to these various materials of this popular lenses, we can see that the Acrosoft material has a refractive index which is about 1.55 and its Abbe number is 37, whereas the Technis material has a refractive index about 1.47, it's an Abbe number of 55. So because the refractive index here in this Technis model is low, the Abbe number is high, so it causes less chromatic aberration. Now, glistenings are also an upcoming a feature that we see many IOLs, and over a period of time we find that many of these IOLs have actually some glistenings developing in this IOL, and this is more commonly seen with the hydrophobic acrylic when they're in the aqueous medium. And nowadays many companies are coming up with new a material that has less glistenings. Now this is spherical aberration is also a very important feature. Again, we see this is a convex lens and we have the parallel rays of light. And what happens is that the rays of light which pass through the center, they pass straight through. The rays of light which are more towards the edge of the lens, they are actually refracted more and they come to a focus which is slightly closer towards the lens. So this causes a spherical aberration. And what the lens manufacturers do is they try to make the lens aspheric so that these rays of light come to a point focus. So by the use of this aspheric IOL with appropriate asphericity value, the contrast sensitivity is increased, spherical and higher order aberrations are decreased, and post-operative visual outcomes can be perfected. And many of these lenses, actually, they tweak the spherical aberration, the chromatic aberration to give a better quality vision. As we can see here, if it's a spheric IOL, the image quality is slightly inferior or much inferior compared to an aspheric IOL. Now, if we come to the various types of lenses that are in the market, still monofocal lenses are the dominant, but then we have the newer entrants. Toric Ios we have since long, and the number of people who are now getting the toric implants are increasing. The surgeons have also become more confident. Multifocal lenses, the EDOF lenses and other types of lenses are gradually also increasing. Now, the toric IOLs are very satisfying to the patient as well as to the ophthalmologist because they do not have this photic phenomenon. On the other hand, they correct the preoperative astigmatism very well, and the patients are very satisfied. In fact, astigmatism is quite common, and preoperative astigmatism, corneal astigmatism, more than one diopter is seen in almost 33% of patients. And we know that more than 0.5 diopter of residual astigmatism can reduce the visual performance and patient satisfaction. And currently, the toric IOLs is considered the most accurate form of astigmatic correction if the patient has an astigmatism of more than one diopter. Now, whom to counsel for toric? Toric IOLs are universally recommended in cases with significant preoperative corneal astigmatism of 1.5 diopter or more. So if we have a regular astigmatism, it's more than 1.5 diopter, we can always advise a patient a toric IOL. Now, how the toricity is achieved? This is because this toric IOL consists of a spherical anterior surface and a toric posterior surface. So it's a posterior surface of the IOL which is toric and which produces the correction of the astigmatic error. So a few points regarding the toric IOL. The most important part is the centration of the toric IOL and the rotational stability of the IOL. So for every 1 degree of rotation, 3.3% of the lens power is lost. 30% of rotation could cause complete loss of cylinder power. And regarding the patient selection, the patient should have regular corneal astigmatism, intact capsule, and the continuous curvilinear capsule rhexis and in the back placement of IOL. So needless to say, the IOL surgery must be perfect so that we can implant these premium IOLs. So before we move to the multifocal IOLs and the EDOF IOLs, let us just discuss the Defocus Card because they will come up now and again. So a defocus card basically is a clinical measure of a lens's tolerance to defocus. A patient implanted with the lens under study views a target at near or intermediate range while progressively stronger minus lenses are put in front of the eye. So if you put more and more strong minus lenses in front of the eye, the lens has to converge more and more. That is, the plus power has to be more and more to bring it to focus. So if you can see this graph, you can see that for the monofocal IOLs, the maximum, the focus is for the far vision, but the intermediate vision and the near vision is poor. For the trifocal IOL, we have 3 peaks. So one is at the far, one is at the intermediate, and one is at the near. In between, there is a trough. So here the visual quality is poor. In case of the EDOF IOLs, for example, the Symphony Iol, we have a peak at the far and we have a peak at the intermediate, and that goes to somewhat near, but patient may not have N6 vision. So the patient has good distant vision and good intermediate vision and somewhat functional near vision. On the other hand, if we have this mono EDOF IOL, so there what we have is this the distance vision is poor and some amount of intermediate vision is there. So the currently the very popular IOLs that we will discuss are the VVT, the Technis Eihans, the Technis Symphony, and the Technis Synergy. Now, what are basically EDOF IOLs? The EDOF means extended depth of focus. So the EDOF class of IOL is an emerging technology that employs new methods to improve the range of vision without splitting light rays. So as opposed to 2 or 3 distinct foci for multifocal lenses, an EDOF IOL smooths out the tips of the defocus curve by creating one elongated focal point. So whereas the multifocal IOLs will have multiple foci, the EDOF IOLs will not split the light. On the other hand, it will elongate the focus so that we can have somewhat good intermediate vision also without the photic phenomenon associated with it. Now, there are various mechanisms, various optical principles that the physicists use to obtain this EDOF. For example, we have this spherical aberration control principle that is seen in some IOLs like the mini IOL ready. I don't think they're available in India at present. But we have this IOL that is the Technis Symphony Iol, and that has something called an echelon diffractive technology. Here, the main optical property is the central part of the lens with a patented diffractive plate designed to correct an elongated focus. So as you can see here, the light rays coming here, this posterior surface of the IOL has this echelon design, and so the light rays cause an elongated focus. And then we have the other technologies called a pseudo non-refractive beam. The non-refractive beam, we will not discuss that. So now we come to this Technis Symphony Iol. The Technis Iol is very satisfying. It produces a very good quality of vision and good contrast. And it's on this Technis platform that the Symphony Iol is made. It has a proprietary echelon design and a proprietary achromatic technology. So it's an aspheric surface. We just studied what an aspheric surface is and how it is good for the patient. This polymer material has a low refractive index. We just studied that if it's a low refractive index, it means higher Abbe number, so less chromatic aberration, so less visual blur. Higher Abbe number, and then we have this a polymer material which is not associated with glistening, and a hydrophilic acrylic material with reduced tendency for the posterior capture or opacification. So here again we see that in a monofocal IOL there is a distinct single focus. In a multifocal IOL there will be 2 distinct foci. In a Technis Symphony IOL there will be an elongated focus. So let's see this animation to make this concept clear. So in case of this monofocal IOL, there's a light distribution. So 100% of the light ray falls on the retina. In case of bifocal IOL, you see the incoming light rays are there. But they're split into 2 foci. In the Symphony, again, there's an incoming light ray. And because of this constructive interference, we can see the light is now focusing onto the retina. And in this process, a large amount of light is focused on the retina, and only 8% of the IOL is actually lost. So the multifocal IOLs work on the principle of simultaneous vision. One image is in focus while the out of focus image is suppressed, and halos are caused by this out of focus image. So this is the advantage of the EDOF IOL. There is no out of focus image. There's just an elongation of the focus. So the photic phenomena like glare and halos are less. So here again, there's an animation to show how this glare and halos are caused by these multifocal IOLs. So here, this is the monofocal IOL. The light is coming to a single focus. There's no glare or no halos. In case of the bifocal IOLs, there is splitting of the light rays. There was a decrease in contrast acuity as compared to monofocals. There's a glare. There is halos. In case of the Symphony, so there is no splitting, just an elongation of the focus. So the halos and the glare are minimum. The other important thing about this Symphony Iol is that it is somewhat resistant to this. If a little bit of postoperative astigmatism is there, then also patient will have a good quality of vision. And if some amount of decentration is there, then also it will not hamper much of the patient's visual acuity. The other IOL that we'll discuss is the Technis Synergy Iol, and this combines two technologies, the multifocal technology as well as the EDOF technology. So let's play this video once.
The Technis Synergy Iol is a breakthrough innovation in presbyopia correction that applies a synergistic combination of EDOF and multifocal technologies to deliver continuous high contrast vision from far through near, even in low light conditions. The profile of the 15 diffractive rings of the Technis Synergy Iol create constructive and destructive interference to optimize light distribution. This modification of the diffractive profile and base curve alter the phases of light. This results in a lens that delivers continuous vision from distance through 33 centimeters. Laboratory testing using an average cornea eye model to visualize light passing through the lens demonstrates the visual performance of the Technis Synergy Iol. The Technis Synergy Iol produces light focused continuously through the range of vision. The Technis Synergy Iol also features Chromoline technology, which corrects chromatic aberration by bringing both high and low wavelengths to a condensed focal point, and optimizes image contrast over the full range of distances. In addition, violet light filtration blocks the shortest violet wavelengths, which produce the highest levels of scatter, while transmitting the longer blue wavelengths. This results in higher image quality through enhanced contrast, and is intended to reduce dysphotopsias by compensating for the visual side effects induced by both advanced IOL optics and the increased use of LED lights in today's world. The transmission of beneficial blue light allows for improved scotopic sensitivity and reduced visual symptoms, as well as improved nighttime driving experiences. Healthy blue light also allows for better systemic health, mood and sleep. These features, along with the pupil-independent design, enable Technis Synergy Iol to deliver superior image contrast in all lighting conditions compared to trifocal IOLs. Technis Synergy Iol is a breakthrough innovation in presbyopia correction that applies a synergistic combination of EDOF and multifocal technologies to deliver continuous high contrast vision from far through near, even in low light conditions, which is essential to the way we live in the modern world. Technis Synergy IOLs. Continuous vision across the range empowers patients to see at their ideal distances. Superior low light contrast delivers high quality vision patients can trust day and night. Get the best of both worlds. Focus far through near. Clarity day and night.
So what basically the Technis Synergy Iol, it has two technologies incorporated in it. One is the multifocal IOL technology and another is the EDOF technology. And because of this, we have both distance vision, intermediate vision and near vision that are relatively good. Now this Technis Synergy Iol combines the EDOF and the multifocal technologies to deliver in the zone continuous vision from 33 centimeter to distance. So if you can see that this is the area of the visual performance between 2020 and 2025 from 33 centimeter to distance. So patient has quite good visual acuity in all the ranges, and it delivers excellent visual performance. And it does not have the pronounced visual gaps of the trifocal IOL technology. So we just saw that in case of the trifocals, there are three peaks at the distance, intermediate and near, and in between there is some trough where the visual the quality is poor. So because it combines the EDOF technology along with this multifocal technology, these troughs, they are not very prominent in this Synergy IOL. So that's the advantage of this type of IOL. Moreover, it can block the violet part of the electromagnetic radiation, and it is said that the LED lights have a very high amount of this violet light, and that is beneficial for this patient. So next we come to the other type of IOL that is called the Tectus Eye Hands. So what the Eye Hands is basically it's a type of a monofocal lens, but it has some amount of EDOF component to it. In fact, 85% of the surface of the Tecnis Eye Hands is the same as the Tecnis single-piece IOL, but the center creates an increase in power to slightly increase the depth of focus. In the US, it's classified as a monofocal IOL rather than an EDOF, with surgical planning attributes of a traditional monofocal lens. So let's see this video to make it more clear.
Imagine an IOL with revolutionary performance that defies monofocal convention by offering enhanced intermediate vision. An IOL that outperforms in low light conditions, increasing confidence in expected outcomes. Introducing Johnson & Johnson Vision's revolutionary next-generation monofocal lens, the Technis Eihans Iol. The Technis Eihans Iol has the properties of the Technis one-piece IOL. It has the same base geometry, the same material, and the same A constant. The Technis Eihans Iol improves vision for intermediate tasks versus the Technis one-piece IOL because it is a refractive lens with continuously increasing power from the periphery to the center of the lens. This increase in power at the center is not based on spherical aberration, but it is due to the local and smooth increase in curvature that delivers enhanced intermediate vision. Because it's a continuous change, it's not visible to the naked eye. There are no rings, zones, or disruptive changes in power. When compared to the Technis one-piece IOL, the difference is so small, it does not affect the general shape or thickness of the IOL. Since the change in power is continuous and smooth, the Technis Eihans Iol provides a photic phenomena profile comparable to the Technis one-piece IOL. The Technis Eihans Iol provides distance vision comparable to an aspheric monofocal IOL and reduces spherical aberration to near zero. We believe this is a game changer. Defy monofocal conventions with the revolutionary IOL.
So this Technis Eye Hands, it has no rings. So the no photic phenomena, it is based on a continuous higher order aspheric surface. And the Technis Eye Hands Iol continuous power profile increases power from the periphery to the center of the lens. So the patient gets very good distance vision compared to a Technis IOL, monofocal IOL. But the patient also gets some amount of intermediate range vision, which is beneficial for the patient. And because it does not have the diffractive rings, there is no photic phenomena, there is no halo, there is no glare. So this is the advantage. So it's a form of a advanced monofocal IOL. So because it gives some amount of intermediate vision, some of the tasks like driving, including night driving, reading price tags when shopping, watching television, cooking, playing cards, and all those things which need intermediate vision, they are possible if you implant this type of IOL. And the proprietary aspheric optic creates a continuous power profile to enhance intermediate vision. We've already discussed that. Next, we come to these trifocal IOLs, and one of the prototype IOLs will be the Ocular Panoptix. We'll see a short video.
Introducing the Acrosoft Iq Panoptix Iol, Alcon's next advancement in presbyopia correcting lens technology. Unlike some multifocal lenses that require apodization to manage light, the Acrosoft Iq Panoptix Iol features a non-apodized aspheric optic. This unique diffractive structure consists of 15 individual steps that allocate light energy into 4 focal points. To optimize performance for a full range of vision, the third focal point is redistributed, amplifying the distance focal point. This design allows the Acrosoft Iq Panoptix Iol to transmit 88% of light to the retina for exceptionally high light utilization in a presbyopia correcting IOL. The diffractive optical structure of the Acrosoft Iq Panoptix Iol has also been designed to provide excellent quality of vision to a wide range of patients. Featuring a 4.5mm diffractive zone, it's less dependent on pupil size than other multifocal designs. And unlike other trifocals with an 80cm intermediate focal length, the Acrosoft Iq Panoptix Iol provides a working distance of 60 centimeters. This is a more comfortable distance for many common activities, such as computer work. The Acrosoft Iq Panoptix Iol is designed to deliver a natural range of functional vision, providing patients with quality sight for their daily activities. The first hydrophobic trifocal lens built on the clinically proven Acrosoft Iq platform, the Acrosoft Iq Panoptix Iol delivers advanced presbyopia correction for your patients.
So for the sake of time, I will not go into these technical details of how this trifocal technology is achieved. We'll next move on to the other IOL, that is this
Devashish, time is less. How much more is
video
there?
on the mechanism of action of
Sir,
the
2 to 3
Acrosoft
minutes.
IQ
Okay,
Vivity
okay.
IOL. Acrosoft IQ Vivity IOL is a first of its kind, non-diffractive presbyopia mitigating IOL that utilizes X-wave technology to stretch and shift the wavefront. Acrosoft Vivity IOL utilizes essentially all light energy, giving patients an extended focal range with a monofocal-like visual disturbance profile. The Acrosoft Vivity IOL's X-wave technology consists of 2 smooth surface transition elements in the central 2.2 millimeters of the IOL. The first surface transition element is a slightly elevated smooth plateau that is about 1 micron in height, and the second surface transition element is a slight curvature change. With presbyopia, the focused light falls behind rather than on the retina when looking at close and intermediate objects.
So we will move on for the sake of time. So there is this slight change in the central part of this anterior part of the lens that modifies the light and brings about this technology. So to sum up, we have several types of lenses to correct this presbyopia. We have the monofocals, we have the EDOF lenses, and we have the advanced monofocals. To conclude, the search of a perfect IOL is still on. There is no perfect IOL now. The search is still on. The IOL selection is not a one-size-fits-all. There has to be a customized approach for each patient. We need to understand the patient's needs, occupation, and hobbies. For example, someone who prefers to read a lot, for that person, a trifocal IOL may be good. On the other hand, someone who does not read a lot but needs more of intermediate vision, such as cooking, there the EDOF IOLs may be better. We must have realistic expectations from the surgery. The patient, we cannot guarantee that despite the best efforts, the patient will not need glasses at all. We should have a clear idea about all the lens options. That was the purpose of this presentation. All the new lenses are there. The basic idea should be there, like the indications, contraindications, benefits and drawbacks. And ultimately, it is not only a good phaco surgery, but it's also a right IOL that makes a patient happy. Thank you. Thank you. That's the end of the presentation.
Thank you, Devashish. The last word of your slide was right IOL, and so much information you have given. It's so confusing. What is the best IOL? And I do not know today if I have to get one cataract surgery done, which IOL I'll go. So we have masters with us. Dr. Mahipal, our chairman, has joined, and we have Mukesh and a lot of other people, Praveen, and for giving comments. I'm not an IOL expert, so I'll request our chairman, Dr. Mahipal, and Mukesh and others to chip in their comments.
Thank you very much. Thank you very much, Dr. Lalit. I think excellent presentation, Dr. Devashish. He has covered the entire gamut of intraocular lenses, and from the time that the IOL came in, there have been significant advances in the IOL technology. There are certain givens now that I think, except for some cases where we still use the non-foldable lenses, the foldable lenses are the standard of care, and there was a silicon material. That silicon material is basically not being used anymore or not being manufactured by any other company. So it is basically an acrylic based, and from a 3-piece, it's gone on to a single-piece lens, except for when you have to do a sulcus placement. The other important thing is that the aspheric lenses made a significant difference. However, the jury is still out as to the exact amount of negative asphericity that needs to be put, because there is no standard at a particular time tomorrow. I think there could be availability of lenses which could actually have the measurement of the asphericity of a particular patient, and then accordingly put an aspheric lens which could have different negative asphericities. But an aspheric lens is today a standard of care. I don't know why still the companies are making these spherical lenses, but because I think there isn't too much of difference in the technology that is required. The next big thing that has come is, I think that was introduced by J&J, and that is the availability of the achromatic lenses. We never looked at the chromatic aberration to that extent. But when you look at all the microscopes, or even if you look at the cameras, the high-end cameras, all of them, the lenses that are used are achromatic lenses. And achromatic lenses especially are good for contrast and dim light vision. So this is something which is definitely a plus, and I think again tomorrow that should be the standard of care. So these are a couple of the things. The material are pretty good. Now, he briefly talked about the toric lenses. I think toric lenses should also become the standard of care, and there is no confusion today that if you have an astigmatism, either you do an LRI or you do, if you are doing a femtocataract, or you do a toric lens. And my tolerance to a toric lens today is that if you are looking at something, anything more than 1 or 1.25 diopters. The other important thing in a toric IOL which is there is to look at the posterior astigmatism, posterior corneal astigmatism, as compared to the just the anterior corneal astigmatism. So that is also something very, very important that has come. Then also the tolerance for astigmatism is important, whether it is with the rule or against the rule. So you have to be less tolerant if you have an against the rule astigmatism. Under those cases, you should be more aggressive to put in a toric intraocular lens. So I think there is very little dispute about a toric intraocular lens, that we should now as an option give toric intraocular lenses. I've been talking to various companies that they should lower the price for low cylinders, because that will increase the penetration of the toric intraocular lenses. Otherwise, if a person has a 3-cylinder or a 3.5 cylinder where the patients are very less, the patient will definitely agree, because he or she knows that the glasses had the cylindrical power. But somebody who has a -1 or 0.75 or something, that person is not that bothered about the cylinder earlier also. So the penetration is slightly lower because the price differential is there. But I think we should always offer a toric lens, and the number of toric lenses have increased. The rotational stability of toric intraocular lenses was also something very, very important. And just small little changes have increased the rotational stability. For example, in the Technis, they have just frosted the haptic. So that's still not available in India, but it should be available soon. And just this frosting of the haptics has helped in increasing the rotational stability of the lens. Now let's come on to the final thing, that is the presbyopia correcting intraocular lenses. I think the accommodative lenses are out of vogue, and none of them have stood the time, whether it was Synchrony, whether it was crystal lens. I implanted a lot of crystal lens, but majority of those patients didn't give any significant near vision to the patient. So I think the crystal lens or Synchrony or whatever, there were more than 40 models of the accommodating lenses, and almost all the research are going down the drain now. I don't think there is anything on the horizon where we are looking at these things. There's another thing which I don't know whether you mentioned or not, but light ablatable lenses is something which are pretty expensive. That is the Callahan lenses, where you can refix the IOL power subsequently for variations both in the sphere and the cylinder, even after the intraocular lens has been implanted within the eye. Now let's come to the last holy grail, and that is the presbyopia correcting intraocular lenses. From the accommodating, as I told you, it is going to be something, and it is going to be not the refractive. The refractive lenses were there. They caused a lot of dysphotopsia. They have gone out of vogue. And as things stand today, the diffractive lenses are there. And ever since we got the trifocal lenses, the bifocal lenses are almost, I would say, in a strong manner, they are almost in their graveyard. Because either you got an intermediate vision or you got a near vision with a distance vision in these bifocal lenses. And whenever you looked at increasing the plus hat, the amount of dysphotopsia was disproportionately higher and the patients wouldn't tolerate that particular thing. So ever since the trifocal lenses came in, I think they have been, whether it is the smoothing of the surface, whether it is the technology, which is the smooth SMPI technology that you have for the Zeiss. I have personally used, I think, more than 700-800 trifocal lenses of Zeiss, even though people consider that there would be an increased PCO, but I think till date, over the 3 years that I have used, I have jagged not more than 5 to 7 cases of this thing, because it's a hydrophobic, hydrophilic lens. There has been not even a single case where I had to explant, and there is not even a single case of Zeiss trifocal lens who is on my head that I am bothered about the dysphotopsias in my eye or the glare or the halos in this. So I am very, very happy with the Zeiss, and also the Zeiss trifocal is available. Now coming on to the next, that is the Panoptix, and on to the Synergy lens. I think Synergy is something which is going to be taking the top deck of the cases. We have done about 40 of them. I think the patients are pretty good. When you're looking at Panoptix, as the video also shows, it is not really a good near vision. It's at 40 centimeters, while when you're looking at Synergy, you're looking at 33 centimeters. So the near vision is much better with the Synergy, plus it is an achromatic, plus it is not, it does not block the light which affects the circadian rhythm. So that is something which is very, very important in the Synergy lens. And the other important thing is that I don't know how Alcon has been able to suppress, but the previous material, now they are changing the material, does have glistening. The fellows who are with me, I show them almost every day the glistening in the Acrosoft lens. And this is of the same material that you have the Panoptix of the Acrosoft lens. So I would be very, very wary of putting an Acrosoft lens, because Alcon being very, very powerful, I don't know how they suppress the glistening. It's only subsequently that people are now talking of glistening free lenses, etc. And that is why Alcon has come out with a new material for avoiding the glistening. Now, the trifocal lenses are going to be there. Trifocal, whether it is Zeiss, whether it is Panoptix, or whether it is Synergy, or whether it is Minivel, etc. All these lenses are working. The EDOF lenses and the Eye Hands, these are the two things that I would wish to say finally. Sorry, one thing in the trifocal lens is that presently the Synergy does not have the toric lens. If you have a degradation in the quality of the vision, and if you have a degradation in the quantity of the vision, it impacts the trifocal lens or the patient much more significantly. So toricity correction is something very, very important, which you cannot leave behind when you are looking at a trifocal intraocular lens. Now coming to the next thing, that is the EDOF lenses. I think EDOF lenses were a way to mitigate the dysphotopsias that were there, the glare and the halos that were there, because they were classically just intermediate vision lenses, and that is what the Symphony was. And we always knew that there is a correction that has to be given in the Symphony, but the patient complaints had gone down significantly, but there was no reading ability that was there at near vision. It was an intermediate vision lens that was there. But the CRV lens, or the continuous range of vision, is combining the trifocal lens along with the EDOF technology, and the amount of dysphotopsia are much less. There are several studies that have come which is comparing the CRV Synergy lens with the Panoptix, and they have shown much better results both in the dim light, as also the contrast, as also the near reading ability. So as of now, if you ask me, my two lenses of choice for a trifocal are either the Synergy or the Zeiss, because I think they are pretty very good in the optics part of it. The game changer that has happened in the monofocal technology is the Eye Hands lens. Unfortunately, we still don't have the Toric Eye Hands, which is available in the US. But Eye Hands lens is definitely reduce the amount of near correction that you are wanting in the patients, and you don't have to tell the patients anything. It is just as good or as easy to implant a Technis a single piece lens, and the patient definitely gets a wow factor. I have done one eye Technis, other eye hands, and the patient says, "What have you done to this eye?" Because I am able to read. I've said that before, but there are at least 4 invasive cardiologists and 3 ophthalmologists that I have implanted the Eye Hands lens. Not even a single one of has had any complaint, and they are pretty good doing their invasive cardiology work as also the operating for the ophthalmologist. So I think an Eye Hands is a no-brainer. And I think it was good of them that we were able to tell them in the advisory board that they should not price it too high, because it has cannibalized significantly a lot of monofocal practice. And that is, I think, the future where it is. And Vivity just about comes and matches up to the Eye Hands, or it is in between Eye Hands and Symphony. And that is going to kill, I think, this lens, because it is priced so aggressively at 70,000 that it does not offer any value for money for being priced at that particular level. So overall, I think exciting times. The presbyopia correcting lenses, as has been said, is not the final word, has not been said, but we are getting nearer to perfection. And once we have that, I'm sure that refractive lens exchange is going to be something that is going to be preferred. If today somebody wants to get rid of glasses, a person 50 years of age comes to me, I would definitely tell them to go in for a refractive lens exchange, not a cornea-based press beyond or anything like that. And I think these trifocal lenses, CRV lenses, are something that is going on. And touch wood, I have not burnt my fingers with any of these trifocal lenses with the patients actually sitting. We have had patients of bifocal lenses where I had to explant, but none of the trifocals of either Zeiss or of Synergy now are actually sitting and troubling us. So that's what I will wish to say. And I think that's my summary of what the lenses are today.
Excellent inputs there. Mukesh or anybody would like to add anything? I think Paul hasn't left anything for you.
I think everything has been covered so nicely. Just a point actually that
one line of personal experience by everybody.
Yeah. So I believe micro monovision still has some place. That is, you implant one lens little bit myopic, and that will give you excellent intermediate vision and working near vision also. And this concept is particularly more useful with Eye Hands. So Dr. Lalit Verma sir, you were asking which lens to opt for. I think for we people, this may be the best idea to opt for Eye Hands, and in one eye just make a little bit more myopic, 0.5 to 0.75 myopic. So that will give us excellent near kind of vision also. So that's one thing. Otherwise, I think my Sir has made everything very crystal clear. And also the presentation was really very nice.
Dipanshu, Praveen, one personal.
Lalit, sorry, one thing. If you are doing a monovision, as Mukesh is saying, the distance, the eye where you are wanting emetropia should be the dominant eye. So you do the dominant eye distance and the overcorrection for the other.
Dipanshu, any personal comment? Your voice is not heard, Dipanshu. No, still not heard. Dr. Praveen was another.
Is it audible?
Yeah, now it is audible.
Yeah, sir, what I just want to say that if I have to put the Eye Hands, then I just try to make it 0 in the first eye, then I try to put in the myopic side in the other eye. Just like sir has told in micro monovision kind of stuff.
So I think for the sake of time, I think we should move on, Devashish, because exciting quiz is waiting.
Yes.
And
yes. So
we should try to finish in time. Yeah.
Right. Yeah. Over to you, Dr. Shubhranshu, for the quiz.
So before we move on to the quiz, I would request everyone to use the web link to connect and post the answers, because The YouTube chat box answers have a time lag, so we will not be able to consider the YouTube chat answers. It will be web link answer. So as we go on to just before we move on to the quiz, we have talked about many international ophthalmic legends. We will just talk about one Indian legend. This legendary ophthalmologist joined the Indian Army post-MBBS and was discharged after contracting a rare form of rheumatoid arthritis at the age of 30 years. He was left bedridden for almost 2 years. But then he went on to become a legend in the field of ophthalmology with more than 100,000 surgeries. But he is best known for developing a high-quality, high-volume, low-cost service delivery model that has restored the sight to millions of people. He was awarded Padma Shri by the Government of India. Google commemorated his birth centenary with a doodle. Yes, we are talking about the legendary Dr. V, our homage to Dr. Govindappa Venkataswamy. So with that, we now move on to the quiz. We call it the eye opener, and just a few basic rules. So as I just now told, please log in using the web link for participating in the quiz. We will have 10 questions. The answers either will be, the questions either will be multiple choice. So you'll have to choose one answer, A or B or C or D, or you may have single or two-word answers. After I have read out the questions, 30 seconds will be given to type out the answer in the chat box. But do not send each answer individually. After the 10 questions are read out, you will be given 1 minute at the end of the 10 questions to collate and send across the answers. So without further ado, we move on to the first question. So here we have a 20-year-old lady with slowly developing unilateral proptosis. What is the most likely diagnosis? Are we looking at A, thyroid ophthalmopathy, B, pseudotumor, C, capillary hemangioma, D, cavernous hemangioma? So we wait for 30 seconds. So this is the first question and 4 choices. A, thyroid ophthalmopathy, B, pseudotumor, C, capillary hemangioma, and D, cavernous hemangioma. Please send in your answers at the end after all the 10 questions are read out, not individually. We are done. Now we move on to question number 2. So here we have a very short video clip, and basically an implant is being shown in this particular video clip. So I would require, this question has no choices. I would require the name, the exact single word name of the implant. This implant was in October, I think in October 2021, it was US FDA approved. We just need the current name, the single word name of this particular implant. We are not onto the implant yet. The process is going on, the photocoagulation of the choroid. The vitreous cavity is being entered. And now we see the implant. So the 30 seconds start now. I need the exact name of the implant. The current name is a single word, and this is question number 2. Please send your answers after all the 10 questions have been read out. We move on to question number 3. So, born in 1564, this famous astronomer, physicist, and engineer has been called the father of observational astronomy. The study of his handwriting and portraits suggest he suffered from unilateral myopia with possible long-standing uveitis leading to secondary glaucoma or creeping angle closure glaucoma. Whom are we talking about? Is it A. Galileo, B. Copernicus, C. Kepler, or is it D. Newton? The 30 seconds start now. This is question number 3, choices being A. Galileo, B. Copernicus, C. Kepler, and D. Newton. So that's 30 seconds. We move on to question number 4. Which of the following was approved by the US FDA in October 2021 for the treatment of presbyopia? Choice A, aceclidine and tropicamide fixed dose combination. Choice B, carbachol combined with brimonidine. Choice C, 1.25% pilocarpine hydrochloride. Choice D, 0.247% pilocarpine with phenylephrine, polyethylene glycol, nepafenac, pheniramin, and nafazoline. So I'm starting my 30 seconds now. This is the 4th question. You can just answer either choice A, choice B, choice C, or choice D. So we'll move on to the 5th question. So here we see central discoid opacity with distinct borders with scattered dot-like opacities visible on retroillumination. By what name is this type of cataract known? Is it an oil droplet cataract? Is it a Kopok cataract? Is it a posterior polar cataract? Or is it a shield cataract? The 5th question, we need to know the name of this type of cataract. Is it an oil droplet cataract A, B, Kopok cataract, C, posterior polar cataract, and D, shield cataract? So here also you can just answer and enter the choices. So we move on to the next question. That's the 6th question, and this one's quite easy. This is basically a relationship relating to the index of refraction in a given medium, an incident light angle to the index of refraction in the new medium. So n1 sine theta 1 is equal to n2 sine theta 2. So this law in physics is named after A, Snell, B, Snellen, C, Fresnel, and D, Huygens. So we start the time now. So the 6th question, you can just give the choices A, B, C, or D. The law in physics is named after Snell, Snellen, C, Fresnel, D, Huygens. Going on to the 7th question. So here we are talking about a 38-year-old male with past medical history of tuberculous cervical lymphadenitis and Crohn's disease with terminal ileitis at 12 years of age. Also had underwent right hemicolectomy and also has enteropathic arthritis. The vision is 20/20 in both the eyes. IOP is normal. Fundus also is clinically normal. So the anterior examination reveals multiple bilateral peripheral large yellow corneal endothelial deposits circumferentially distributed, sparing the central cornea. What is the most likely cause of these deposits? A, clarithromycin induced, B, Crohn's disease, C, rifabutin induced, or D, are these just mutton fat KPs? So the 7th question, either of the 4 choices, the most likely cause of these deposits? A. Clarithromycin induced, B. Crohn's disease, C. rifabutin induced, or D. Are we just looking at mutton fat KPs? We go on to the 8th question. Express shunt. Is this an eye stent? Is this an eye stent inject, or is this a hydrous micro stent? So this glaucoma implant, is it A. express shunt, B. eye stent, C. eye stent inject, or D. is it the hydrous micro stent? So this is the 8th question. Now the 9th one. So this is a case wherein you have to give the answer. It is a 2-word answer. So we have a 39-year-old non-diabetic, non-hypertensive vision. The 9th question, you will need to give the answer. It's 2 words. These are 2 words basically. So it's non-diabetic, non-hypertensive, alcoholic woman, abdominal pain, and these characteristic fundus appearance bilaterally. What's the most probable diagnosis for this ocular condition? And finally, we go on to the last question. And this is the pathology from the corneal button of a patient complaining of decreased visual acuity. The stain that has been used is mesenteric. What condition is being shown here? Is it A. epithelial basement membrane dystrophy, B. granular corneal dystrophy, C. lattice dystrophy, or is it D. Lish corneal dystrophy? So we start the time, the 10th question. Once again, 4 choices: A. epithelial basement membrane disease, B. granular corneal dystrophy, C. lattice corneal dystrophy, or D. is it Lish corneal dystrophy? The mesenteric stain, I guess, is the clue here. So we have finished the quiz, and now I will give 1 minute's time for sending across the answers. It should be on the chat box, and it should come as a single chat. We have started receiving the answers.
Dr. Sengupta, how much time will you take to collate?
I think 5 minutes, sir. We have 10 seconds more.
Yeah.
Yeah, we have 10 seconds more, and now we will stop taking answers now. I'll just take time to collate the answers.
So what I'll do is I'll just share screen for a couple of seconds. So what I thought was it's a celebration time for Center for Sight. And why I say so is because of the following reason, that very recently again, Center for Sight again adjudged as the best private eye hospital in the country. I think this needs a huge applause from everybody. And it says successively that Center for Sight has been adjudged as the best private hospital. The other applause, congratulations to Dr. Babita for making us proud for doing great work in the Center for Sight in the eastern part. These are a couple of newspaper cuttings which I came across. I thought I'll share with all of you the great work. Because all these good works, done all across our own centers give you an inspiration to work harder. And it's no less achievement, you see, to have, being adjudged as the best Center for Sight. So let's have Dr. Mahipal's opinion on this and how has he, reached this level, and also on Sabitab's also. Dr. Mahipal is there?
Yeah. So I think it's basically the team of the excellent surgeons that we have, which the Hansa research, which carries on this, is looking at peer review in the sense that what doctors feel as to which are the best hospitals, and then they ask the general public, and then they ask within the specialty. I think this is the third year in running that we are in the top private eye care hospital that is there. Because if you look at the list, all the other hospitals are actually in North India. The only other private hospital, fully private, rest are all either NGOs or the government hospitals. So NN has been ahead of us in all these years. And Week is predominantly a South India based magazine, which has a lot of credence from Kerala. So I think what stands out is the doctors, which is the most important. I think that is where consistently Center for Sight has been able to attract the very best in their fields, in their regions, or I would say internationally also, to be part of Center for Sight. And the second important thing I would say is the availability of cutting edge technology that we have. I think if you look at various groups, we are the most technologically advanced and most penetrated technology that we have. The team is the other important thing, which is the backbone of being able to provide the services, and the operations are something which is very, very important. The quality team, I think majority of our centers are now NABH accredited, and that adds a significant impetus for us to maintain the quality and the patient listening. It's obviously the good work that goes, it's the word of mouth that goes, and I would say that the listening of Center for Sight has grown over the years, and I wish to thank each one of you who has participated in this growth of Center for Sight, and we look forward to continuing to give the very best to the patient. And obviously we have the efficiency, precision, compassion, and integrity as our hallmarks. So Lalit, that's what I will wish to say. Dr. Lalit, Dr. Harsh, Dr. Dinesh, then Babu, Santosh, Pradeep, Dr. Pradeep has joined now, Pradeep Vyas. I think you can just keep on counting. Dr. Santosh, for example, is the only one who's been gone into the Hall of Fame of the American Academy of Ophthalmology. And today, it's again something very proud that I'll wish to say is that the consistency with which iFocus is going on, the viewership of iFocus is higher than any AIOS program that is being done today. And within a week of an iFocus program being aired, it crosses 6,000 to 10,000. It ranges between 6,000 to 10,000 views within 7 to 10 days that you have of iFocus. So I think, as Lalit was saying, exactly, there are lot many things that bring up the peg, and the community services also are taking more route that we are having, and we keep on trying to do better than what we have done and keep setting standards which are better than before. So thank you very much. I would say the entire team of the doctors, the staff, and everyone, I would say, who is contributing to the success and making Center for Sight as the preferred destination for the patients.
You see, I must say iFocus program, because nowadays Retina module is going on and 155 episodes are already there. And I, in my spare time nowadays, do visit that YouTube, frequently. And the viewership is so high, so high. And Ajit Babu also, is regular in the Retina modules, which are, yesterday only we did one module on fluorescent angiography, and tomorrow we have to do again on IC angiography. And viewership is going leaps and bounds. And everybody is appreciative of this program. Congratulations to everybody. So, Sengupta, are you ready with the result?
Yeah.
So yes. So I'll just quickly run through the answers and then give out the winners.
Yeah, sure.
Okay. So the first question, this 20-year-old lady, the first answer is D, cavernous hemangioma. Second one is the Susbimo implant. The third one, Galileo. The fourth one, the US FDA approved for the treatment of presbyopia. It is the pilocarpine 1.25% one. Then the cataract that we are talking about is Cobo cataract, or the central pulvirulent cataract. This particular law is the Snell's law. Dr. Devashish had shown in his presentation as well. Then here we were talking about the rifabutin in related corneal endothelial deposits. And as far as the implants concerned, express shunt no, iStent no, iStent inject no. This is actually D, Hydrus microstent. The ninth question, well, this was a non-traumatic presentation of Purchase retinopathy. And the last one, the 10th question, it was granular corneal dystrophy. The material stained with mesenteric was hyaline. So we have 2 people who answered 9 questions correctly. The winner is, he defeated the Dr. Krishna is the winner with 9 correct answers. And second would be Dr. Isha Chaturvedi. Her answers came in just 50 seconds after Dr. Krishna. She also has 9 correct answers. And we have 3 people tied on 8 correct answers. But we received a response first from Dr. Yusra Asal. So he's the 3rd prize winner. So Dr. Krishna, the 1st prize winner, Dr. Isha Chaturvedi, 2nd, and Dr. Yusra is the 3rd prize winner.
Great, so, congratulations.
So at the end, we would like to thank everyone who's been with us today, this evening. Very big thank you to Dr. Mahipal Sachdev sir for being the, the guiding beacon for all of us. Thank you, Lalit sir, for guiding us, for mentoring us through this session. A big thanks to Dr. Ritika Sachdev for conceptualizing this online format. And of course, Dr. Tulika Chauhan for her untiring work behind the scenes. She's kind of the backbone for this particular program. And also a huge thanks to the whole CFS Parivar from Eastern Chapter of Center for Sight. Thank you, everyone. Over to you, Lalit sir.
So thanks a lot, the CFS team. And today it was, although we slightly overshot the time, but it's a nice meeting. And I think there's a lot of learning here. And so let's wait for the next episode. And my constant endeavor here is to promote competition. As I said, the best of the best team gets the chairman's trophy. So this was an excellent performance by the East team. And I wish the West team, which will be done by Dr. Rupal, I think Rupal is already here, and Dr. Vaidya, they will be gearing up for the West. So hope to see you, all of you again in the December month last week. Thank you so much, everybody, for joining.
Sir, I wanted to say one thing. This is Tulika.
Yes, Tulika. Where are you?
I'm proud that all the 3 prizes goes to our fellows.
So that shows the amount of training, Tulika, you're doing.
So we
you
all
are in charge of.
I'm not the only one, but I'm so glad.
Yeah. So
I think we should start fellowship elsewhere. That's the take home message, right?
Yeah.
Great. Yeah.
Thank you.
Thank you, Dr. Mahipal. Thank you, everybody, for joining.
Thank you.
Hope to see you soon. Thank you so much.
Thank you, sir.
Good night.
Bye, 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 everybody.